I'm Dr. Stuart Spechler. I'm the Chief of Gastroenterology at Baylor University Medical Center and co-director of the Center for Esophageal Research at Baylor Scott and White Research Institute. And today we're going to be talking about obstacles to cancer prevention in Barrett's esophagus. So for the past 4 decades, our strategy for preventing deaths from esophageal adenocarcinoma has remained essentially unchanged. We screen individuals with GERD symptoms and other cancer risk factors to identify those who have Barrett's esophagus, and we enter those patients found to have Barrett's into regular endoscopic surveillance programs that are designed to identify curable neoplasia in the form of dysplasia and early cancer. Now, during the same 4 decades that we've been using this strategy, the incidence of esophageal adenocarcinoma has increased more than 6-fold in men and more than 4-fold in women. And these computer models project that that increase is going to continue at least through the year 2030. You certainly can't point to these data as support for the success of our screening and surveillance strategy. And look at this meta-analysis of 11 studies that evaluated the pooled prevalence of a prior diagnosis of Barrett's esophagus in patients who present to the hospital with adenocarcinoma. Only 11.8% of patients who were found to have esophageal adenocarcinoma had a prior diagnosis of Barrett's esophagus. So clearly, our screening program is not working very well if we're missing almost 90% of the patients who are going to develop esophageal adenocarcinoma. But despite this compelling evidence that our whole esophageal cancer strategy is failing, the strategies remained essentially unchanged for the past 40 years. Well, if insanity is doing the same thing over and over again while expecting different results, then I think our adherence to this failed strategy seems to be insane. Now, a critical first step towards developing an effective cancer prevention strategy is to understand why the present one has failed. Well, one contributing factor undoubtedly has been our policy of requiring that patients have GERD symptoms in order to qualify for Barrett's screening. But a number of studies have shown us that only about 40% of patients with esophageal adenocarcinoma ever report a history of GERD symptoms. So right off the bat, our screening policy misses at least 40% of patients who are going to develop this deadly tumor. Another proposed reason why the surveillance strategy has failed is that it's based on a traditional concept that esophageal adenocarcinomas develop through a gradual linear progression of molecular alterations in the intestinal metaplasia of Barrett's esophagus. But in fact, only about 40% of these cancers develop through this slow traditional pathway. Rather, 60% of Barrett's cancers develop through a genome doubled pathway in which cancers can develop much more quickly, perhaps quick enough to progress to invasive cancer in the 3 to 5 year interval between scheduled surveillance endoscopies. Now, Dr. Elsarag and his colleagues have pointed out that Barrett's risk factors that we use to identify patients for screening, things like age greater than 50 years, GERD symptoms, and obesity, have very limited specificity. Well, yeah, I mean, 1/3 of the population of the United States is older than age 50. 20% of adult Americans have GERD symptoms, and more than 40% are obese. So these risk factors are ridiculously nonspecific. And some of the important risk factors, like increased abdominal fat, are not easily gleaned from the electronic medical record. But as important as all these shortcomings might be, I'm going to contend that perhaps the major factor limiting the efficacy of our esophageal cancer prevention strategy is that we have failed to acknowledge the importance of short segments of intestinal metaplasia that can be found in normal or irregular Z-lines. Now, I've taken somewhat of a maverick position on this issue, but a debate that Dr. Elsarag and I had on the issue was published in the April issue of the American Journal of Gastroenterology. And this is the point that I'm going to focus on for this talk. So for this discussion, I think it's important to appreciate how much the definition of Barrett's esophagus has changed over the years. In 2002, the ACG said that Barrett's esophagus is a change in the esophageal epithelium of any length that can be recognized at endoscopy and is confirmed to have intestinal metaplasia by biopsy of the tubular esophagus. But in 2016, the ACG said that Barrett's esophagus should be diagnosed when there is an extension of that salmon-colored mucosa extending at least 1 centimeter proximal to the esophagogastric junction, with biopsy confirmation of intestinal metaplasia. And they went on to say specifically that biopsy should not be performed in the presence of a normal Z-line or a Z-line with less than 1 centimeter of variability. And the latest update on the guidelines says the same thing. So why did our GI societies change their diagnostic criteria for the condition? Well, this 1 centimeter requirement for a Barrett's diagnosis was based on 2 premises. First, that there's poor inter-observer agreement in identifying segments of columnar mucosa that extend less than 1 centimeter up the esophagus. And second, that segments of esophageal metaplasia less than 1 centimeter in length have a negligible risk for cancer development. So how valid are these premises? I think premise number 1 is valid. In this study by Pratik Sharma, 29 endoscopists were asked to assess the extent of Barrett's esophagus in endoscopy videos for 29 patients. And agreement was assessed using kappa values. So recall that kappa values less than 0.4 indicate poor reliability. Values of 0.4 to 0.75 are fair to good, and kappa values greater than 0.75 indicate excellent reliability. Well, the kappa values were okay for identifying Barrett's of any length or longer than 1 centimeter. But for Barrett's length less than 1 centimeter, the kappa value was a very poor 0.21. So it appears that endoscopists cannot reliably distinguish an irregular Z-line from a short segment of Barrett's esophagus or from the condition that we call intestinal metaplasia at the EG junction. So there is poor inter-observer agreement in identifying segments of columnar-lined esophagus less than 1 centimeter, and that would be good reason to ignore them if the second premise were true, that short segments of esophageal metaplasia have negligible risk for cancer development. But that premise is a lot more questionable. It's well established that the risk of neoplasia in Barrett's increases with the length of the metaplastic segment, and that makes sense. If the individual metaplastic cells all had the same malignant predisposition, then longer metaplastic segments should have a greater cancer risk than shorter ones because the longer segments have a lot more cells at risk. But the risk of neoplastic progression in Barrett's is likely to involve more than just chance related solely to cell numbers. Short segments of intestinal metaplasia are located at the junction between 2 epithelial types, squamous and columnar epithelium, and that might be a hot spot for malignancy, as it is in the uterine cervix. In addition, exposure to carcinogenic acid and nitric oxide is most intense in the distalmost esophagus, where those short segments of intestinal metaplasia are found. So short segments of esophageal intestinal metaplasia may well have a greater cancer risk than you would predict solely on the basis of cell numbers. Now, data on the cancer risk for these short segments of intestinal metaplasia are very limited. In fact, I only know of 4 of these studies, and they all have suggested that short segments of intestinal metaplasia have negligible cancer risk. I don't have time in this talk to examine these reports for you in detail, but these are all relatively small studies. They had meaningful follow-up on fewer than 100 patients. 3 of the 4 were retrospective. 3 of the 4 had no standardized biopsy protocols, and the single prospective study excluded some unspecified number of patients who had prevalent dysplasia, that is, dysplasia in short segments. Suffice it to say that none of these studies can be considered definitive. But these 4 studies would have you believe that segments of intestinal metaplasia less than 1 centimeter in length have negligible cancer risk. But look at this study. Now, this focused on the frequency of intestinal metaplasia less than 1 centimeter in patients who had newly diagnosed early esophageal carcinomas. Now, investigators at this German referral center for the endoscopic treatment of Barrett's reviewed their experience with more than 1,000 patients who had newly diagnosed T1 esophageal cancers. 56% of those cancers were in long segment Barrett's esophagus, 24% in short segment, but 20% of all the newly diagnosed T1 esophageal cancers were in patients with intestinal metaplasia extending less than 1 centimeter above the EG junction. These patients wouldn't fulfill the modern diagnostic criteria for Barrett's esophagus. And this study almost certainly grossly underestimates the frequency of cancer arising from these short segments of intestinal metaplasia, both because it's a referral center that sees referrals for patients who are already known to have Barrett's, and because they specifically excluded cancers that didn't have any associated intestinal metaplasia. And as we'll discuss in a moment, those are especially likely to have arisen from short segments of intestinal metaplasia. Now, in fact, intestinal metaplasia often is not found in association with esophageal adenocarcinomas. Now, here's a study of 2 large cohorts of cancer patients, one from the Mayo Clinic that included 411 patients with esophageal adenocarcinoma, and this Occam's cohort from the UK, more than 1,400 patients with cancers diagnosed at 25 sites around the UK. In both cohorts, more than 50% of patients, those are the orange bars here, had no intestinal metaplasia found in the esophagus that harbored their cancers. Well, since Barrett's metaplasia is the only known precursor of esophageal adenocarcinoma, the likely explanation for the absence of intestinal metaplasia in these cancerous esophagi is that the cancers grew over or replaced the intestinal metaplasia from which they arose. Well, if that's true, then tumors with no associated metaplasia likely arose from very short segments of intestinal metaplasia, since a tumor would have to be enormous to eradicate all evidence of a long segment Barrett's esophagus. And consider this report, Sachinwani's analysis of GI quick data, which concluded that endoscopists often ignore Barrett's esophagus guidelines. There were more than 13,000 cases in which endoscopists, contrary to guidelines, took biopsies from a normal appearing Z line. And look at the prevalence of intestinal metaplasia in that group, 38%. More than 1/3 of biopsies from a normal Z line showed the intestinal metaplasia that gives rise to esophageal adenocarcinoma. And what I found most disturbing about this study was an issue that was not the major focus of the investigation. Look at the prevalence of dysplasia in those normal Z lines. Low grade or indefinite in 7.4%, high grade dysplasia in 2%. In fact, the prevalence of dysplasia in these normal Z line patients was higher than that in their 89,000 patients with short segment Barrett's. That's a lot of dysplasia for a lesion that's supposed to be innocuous. Well, here are my take on these data. First of all, intestinal metaplasia in normal or irregular Z lines is extremely common. And it's very clear that this metaplasia in these normal and irregular Z lines has some malignant potential. And although the cancer risk for these short segments may well be a lot less than for long segment Barrett's esophagus, with so many more at-risk individuals, it seems very likely that many, if not most, esophageal adenocarcinomas might develop from intestinal metaplasia in normal and irregular Z lines. And that suggests that our current cancer prevention strategy that ignores these short segments of intestinal metaplasia can have only very limited efficacy in decreasing deaths from esophageal cancer. I think this is a real fundamental problem, and I think it's high time that we come to grips with this very fundamental issue. But don't misunderstand what I'm saying here. I'm not saying that now we have to go out and biopsy a bunch of normal Z lines, because what would we do with all those new patients that we would identify by doing that? We'd enter them into our surveillance program, and the surveillance program's never been shown to be effective. Now, I think it would be perfectly appropriate to conclude that expanding our screening efforts by biopsying all normal Z lines would require resources that we simply don't have and that can't possibly be a cost-effective strategy. No, what I'm arguing for now is that we really need to take our heads out of the sand and stop saying that these short segments are innocuous. Our current Barrett's cancer prevention policy focuses on the tip of a very large iceberg, the patients with endoscopically apparent Barrett's esophagus. For every one of them, there's 10, maybe 100, maybe 1,000 patients with intestinal metaplasia in normal and irregular Z lines. And individually, those patients have a low risk of developing cancer, undoubtedly a lot lower than the patients with the longer segments of Barrett's. But there are so many more of them. If you multiply a small risk by that very large number, that adds up to a lot of cancers. So if these short segments of intestinal metaplasia really are the source of many, if not most, esophageal adenocarcinomas, and we refuse to recognize that fact, then I think we'll continue to see a rising death rate from this cancer. Presently, it does not make sense to expand screening efforts for Barrett's esophagus merely to enter more patients into ineffective surveillance programs. What we need is an effective tool for risk stratification. If we had a reliable risk stratification tool, we might be able to identify patients at high risk for progression to cancer and send those patients for endoscopic eradication therapy. And for the patients that we identify at low risk, maybe we could expand surveillance intervals or maybe not even bother with surveillance at all. But the closest thing that we have to it at the moment is TissueCypher. The TissueCypher approach uses a systems biology approach for predicting neoplastic progression. It views tissue as a system made up of multiple compartments that can be analyzed quantitatively for genetic, immunologic, vascular, and morphologic features associated with neoplastic progression. It uses formalin-fixed, paraffin-embedded Barrett's biopsy specimens that are analyzed for a whole panel of biomarkers that might be associated with neoplasia. It includes biomarkers for epithelial cells, stromal cells, and immune cells. And these are biomarkers that assess a variety of features like the well-known epithelial cell abnormality p53 alterations, but there's also markers for angiogenesis and immune cell subsets. These also might be contributing to cancer progression in Barrett's. Now that process starts with multiplexed immunofluorescence slide labeling for 9 protein-based biomarkers with whole slide fluorescence scanning for those particular markers. The TissueCypher image analysis platform takes 15 quantitative measurements of the biomarkers and the morphologic features, and it integrates it to provide an overall risk score ranging from 0 to 10 that you use to categorize each patient. And this is what a clinical analysis might look like. You're given a risk score, in this case, 7.8. It tells you that this patient is at high risk with a 14% 5-year probability of progressing to high-grade dysplasia or cancer. And it also provides you with this graph showing the probability of progression within 5 years. Now, TissueCypher is the best studied of our risk prediction tools. To date, there's been 5 independent studies that have included 239 progressors. Those are the Barrett's patients who were found to progress to high-grade dysplasia and cancer, and 656 non-progressors. And this is at medical centers in the United States and Europe. Overall, these case control studies show consistent, strong, and significant associations between a high-risk score and progression to high-grade dysplasia and cancer, and between a TissueCypher low-risk score and lack of progression to high-grade dysplasia or cancer. Furthermore, patients with non-dysplastic Barrett's who scored high risk by TissueCypher progressed to high-grade dysplasia and cancer at a rate higher than an expert pathologist confirmed diagnosis of low-grade dysplasia. So here are data from 268 Barrett's patients. 58 progressors, 210 non-progressors. And here you can see the baseline diagnosis of these Barrett's patients by expert GI pathologists. Compared to non-dysplastic Barrett's, the pathologist's finding of low-grade dysplasia predicted a 3.8-fold increase in progression to neoplasia, with a positive predictive value of 21.8% over a 5-year period. Now, if we now look at the TissueCypher risk classifier in the patients that the expert pathologist said had non-dysplastic Barrett's esophagus, the high-risk group in that non-dysplastic Barrett had a 5.1-fold increase in progression with a positive predictive value of 26% over 5 years. So this suggests that TissueCypher is a very promising technique for risk stratification. But my longtime science partner, Dr. Ron D'Souza, along with Dr. Rebecca Critchley-Thorne from Castle Biosciences, have just begun an NIH-sponsored study called the SCRIBE study that's going to assess the performance of TissueCypher in risk stratifying an unbiased cohort of patients with non-dysplastic Barrett's esophagus. Now, this is not a prospective study per se, but it's going to use a novel study design that I think is the closest thing we'll ever get to a prospective study for non-dysplastic Barrett's esophagus. Patients with non-dysplastic Barrett's who were diagnosed between the years 2013 and 2016 at a community-based GI practice center who also had at least one subsequent endoscopy will be considered. And the first 2,000 patients whose baseline histology is confirmed as non-dysplastic by our expert GI pathologist is going to comprise the unbiased study cohort. So we consider it unbiased because these aren't patients cherry-picked because they're known to have neoplastic progression. This is a typical Barrett's patient coming to a community practice. TissueCypher will be performed on serial sections from those same biopsies, and our expert pathologist will review the histology from all subsequent endoscopies over the next 5 or 10 years to characterize whether they're non-dysplastic, dysplastic, or cancer. And the primary outcome here will be the accuracy of TissueCypher for predicting the development of high-grade dysplasia or cancer. Thank you very much for your attention today.